Talk wealth. Talk politics. Talk 1470. WNN.
The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. Welcome to the CareGiver reality show with your hosts, David Levy and Paul Vadiato, who bring you more than a combined 25 years of practical experience, helping thousands of family caregivers, helping them find solutions to the challenges and frustrations presented by this important responsibility. So if you are in the position of caring for a spouse or a parent, a loved one who is no longer able to care for themselves, or if you know someone who is, this hour will be worth the listening. Now, let's tune in to today's edition of CareGiver Reality with your hosts, David Levy and Paul Vadiato.
That should be hosts, in plural. Anyway, good evening, South Florida, America, and the world. It's Tuesday at 5 o'clock, drive time for anybody from Vermont to the Keys and anywhere east of Ohio. So we hope you're listening while you're in the car or you're watching us on caregiverreality.com. If you want to talk to us, we're at 1-888-565-1470, and you're hearing us on WWNN 1470 AM, broadcast also on iHeart, and I don't know where else, but the numbers keep growing, so we're happy campers. And just remember that Caregiver Reality is a program that's devoted to you, the unpaid family caregiver. There are depends on whose statistics you use, is anywhere from 50 to 90 million. I kind of always have said of late 50 to 60 million, but there's an awful lot. And most of the information out there for caregivers really doesn't get down to the issues that Paul and I think are so important, and that's practical problem solving. The clinical issues of your loved one are reasonably well attended to by the medical profession. We all know a lot about what our loved ones are suffering from, but we really don't get the kind of support and help that caregivers need besides a list that says take good care of yourself and go get respite. Most people, if they wanted respite, don't know where to find it. And take good care of yourself, we've been telling you that since you've been one. All right? And so think about it. It's useful, but if you don't know how to implement it, you've got some real difficulty. Anyway, we've got a wonderful call-in guest tonight, a gentleman by the name of Ron Calhoun. He's the National Healthcare Practice Leader for the largest insurance company in the world. And not that we're going to get into any insurance speak or any, babble like that, but he's at the bleeding edge of what's happening out there in healthcare, and he's one of my gurus that I go to when I really want to find out what's happening before it happens. So he'll be coming on around 5:20, 5:25. I know tonight we're competing with the soccer game, Go USA, but if you got a few minutes for us, we'd really appreciate it. Anyway, Paul, how was your week?
Well, first of all, good afternoon, David, and good afternoon to all of our listeners. I knew you were going to ask me that question.
I ask it every week.
I know. It's been a very odd week in my world of caregiving.
And it's only Tuesday.
My beautiful wife, Debbie, was supposed to be a guest here on the show tonight and be part of our discussion. And she's not with us tonight because the nature of the caregiving that I do is that the world is a maybe. You never know until that last moment. For those listeners who are joining us for the first time, my wife has lupus, which is an autoimmune disease. It's among a family of diseases such as fibromyalgia, MS, multiple sclerosis. And what it basically is, it's the immune system of the body attacks itself. And one of the commonalities is intense pain. So caregiving on Sunday was a wonderful day. She was feeling her old self. We went out. We were husband and wife. There wasn't a caregiver in the house. And Sunday night, I heard I'm not starting to feel so well. And when I left tonight, she was in bed after being there now for 2 days. And the last words out of her mouth was, "I'm so sorry to disappoint David and your listeners tonight." She has a very, very important story to tell for a new topic that we're going to talk about a little bit later. And she wanted to be here to tell it tonight. So, Debbie, feel better, and we're looking forward to having you here in studio. How's
Right.
that for a long answer?
Well, it's an accurate answer, and I always know because, for 15 years my wife doesn't have lupus, but hers is an autoimmune disease, fibromyalgia, chronic fatigue, fainting, a whole bunch of things that go on. And I cannot tell you that our friends, those that are left, always knew that at the last minute we were the cancelers. How many times did it get, we'll meet you at the restaurant at 6:30, and at 6:15 I call up to indicate that we're a no-show. And after a while people stop making arrangements with you because, and it's not her fault. You just never know in caregiving, especially with autoimmune diseases, and the more we're learning about them, and when you find that the body actually attacks itself, these are so difficult to control and so unpredictable. And so folks out there that are dealing with their own caregiving issues, whether it's in the nature of dementia, autism, folks with cancer, stroke, it really doesn't make a difference because when you're a caregiver, you've been assigned a role and a responsibility that genuinely takes an awful lot of your time, a tremendous amount of your effort, and requires a set of skills that we really don't intuitively have. And what do I mean by that? I mean, we learn at an early age things that we're supposed to do, not do. We learn from our parents, and good, bad, or otherwise. Then we learn from books, and there's a whole generation that's learning from the internet and learning. And we as boomers, Paul and I, even though I'm a little older, I'm an edgy boomer, if there is such a word. We learned off the TV. And in this day and age, education comes from a lot of different places. And even though there's a lot of books that have been written and folks that are out there to tell you what services are available, very few are in a position to tell you how to do the practical problem solving that comes up every day as caregivers try and deal with the doctor, deal with the lawyer, deal with the finances, deal with the system, deal with a whole myriad of things that they used to know how to do for themselves. We all know how to take ourselves to the doctor, but do we know how to go to the doctor and be an advocate for a loved one, let's say, that has dementia, can't speak for themselves? And the doctor looks at us as caregivers, and it's kind of like we have a green head, because the doctor's not skilled in caregiving.
Right.
He didn't take a course in it. Very few people ever have. And so we tend to marginalize the caregiver in the clinical system as the taxi driver for the patient.
Well, and as a caregiver, the lines begin to blur between spouse or brother, sister, mom and dad, and then the role as a caregiver. And sometimes you really feel very, very conflicted in what you you need to do versus what you would wish you didn't have to do. Fighting the system, extraordinarily difficult, and being there for that person that you care for, and being there in a way that really maintains dignity and quality life. It's a challenge day to day, and for those of you who are caregivers, you have our greatest respect and admiration, because it is a job that is so difficult and so unrecognized.
And that's the truth. And Paul speaks as a caregiver, I speak as a caregiver, I speak as somebody that has been caregiving for an awful long period of time. There's a caller online. Caller? Are you there? Caller? You've reached the show. Well, maybe they thought they were ordering a pizza. Extra large with cheese? Yes, ma'am. We'll have that right out. In any event, we might as well move along if that caller wants to call back, but they need to call soon because at about 5:20, 5:25. Oh, you know what? It's our call-in guest, and he has called in early. So I'll tell you what. Why don't we jump? I have Ron Calhoun on the line, and we're going to jump in there early, and we'll pick him up, and we'll scramble the rest of the show a little later on. So, Ron, are you on?
It's like caregiving.
Yeah. Ron?
Yes.
Okay. Good afternoon.
How are you?
We're fine.
Hey, Ron, this is Paul. Welcome.
Hi, Paul. How are you?
Good. Can we ask you to speak up a little bit?
Can you hear me now? Is this any better?
Yeah, that's better.
Yes, thank you.
And as I said earlier, Ron Calhoun has been a good friend of mine for a long, long period of time, which kind of tells both our ages, although he's much younger, is the National Healthcare Practice Leader for Aon, and he's responsible for helping Aon healthcare provider clients protect against business risks. Now, that sounds like a lot of gobbledygook, but Ron will break it down and make it very, very simple. And just so that you know, Aon is the leading global provider of risk management services. Obviously, in the healthcare industry, and the more you hear about it these days, everybody is taking risk. They want the doctor to take risk. They want the provider to take risk. They want the insurer to take risk. And there are a couple of major companies out there that really understand what's going on and try and create solutions so that people can get what they're looking for, and those that have to give it to them can also try and control and mitigate their risk. Did I do a reasonable job of describing that, Ron?
Very well done.
Okay. And so, in any event, even though we're competing with World Soccer, and I hope I didn't take you away from it tonight, I wanted to discuss with you and ask a few questions. Since you're out everywhere these days on behalf of the company, and you're a very smart guy, what are the two biggest challenges that you see for the healthcare industry? Both, we see it for the caregiver, but, you know, more importantly, the patient, the family that's out there. What do you see as the two biggest challenges that we're going to be facing in the next couple of years?
Well, that's a very open-ended question, and there are many challenges. But from a provider perspective, from a healthcare provider perspective, I would have to say that the most challenging dynamic that they're facing right now in the transformation that they're going through, not only as a result of the Affordable Care Act, but also what's going on the commercial front, I would have to say that it's the migration away from, or the movement away from fee-for-service payments for care towards more value-based reimbursement methodologies. That requires a fundamental shift in the way a healthcare provider behaves. Some providers are going to now be charged with the responsibility of managing the entire spectrum of care as opposed to treating specific diseases or conditions.
So would it be safe to say that in breaking it down to keep it simple for me, that the old version of going to the doctor because you had something wrong with you and you paid to see him and he said, come back and see me in a week, and you paid to see him the next time with your insurance or without, paid your copay, and that was essentially how the disease was handled. I'm not talking about whether you had to go in the hospital or not. Now, if I understand what you were saying, that the value-based or bundle is that the provider, whether it's a doctor, whether it's a hospital, whoever is wearing that white clinical hat, is now going to be responsible for managing the total course of whatever that illness, disease may be, for something that resembles a fixed fee. Would that be close to what you were referring to?
That's correct. That can take many, many forms, and there's a whole continuum from simple shared savings models all the way to fully bundled arrangements. But the part of the historical problem, and the reason why we were dealing with double-digit medical trend for a number of years is an interesting thing happens when you pay any service provider for volume. What ultimately happens is that service provider generates volume, and it's somewhat of a perverse incentive. And we were reaching the point where we just had to fundamentally, as a system, change the manner in which we're paying our healthcare providers. So we are making this transition to what is commonly referred to as value-based purchasing, which is simply a concept that links payments directly to the quality of care provided. And it's a strategy that can help us transform the current payment system by rewarding providers for delivering care that meets the three tenets of the Institute of Healthcare Improvement's triple aim. This is a fundamental goal of all of the ACOs, or accountable care organizations, and that is to improve health outcomes, lower costs, and ensure high-quality, patient-centered care. But like I said earlier, there's a variety of payment transformation models that are emerging, both on the statutory front from the Medicare and Medicaid perspective and on the commercial front. And they, like I said, they range from very simple shared savings models all the way to the fully bundled arrangements that you were alluding to earlier.
And when you say the fully bundled arrangement, Ron, let me just, for the benefit of our audience, and you correct me, but let's just say you broke your hip. And there are certain clinical codes that are called ICD-9, we're now moving into ICD-10, that kind of identifies what the medical predicament is. And there is normally a course of events for that diagnostic code in order to get better. And it may require both hospitalization, seeing a lot of specialists, and the anesthesiologist, or whatever else it may be, each of whom historically has billed individually. Now, if I understand you, when you come in with a broken hip and the ICD code or whatever it may be identifies the spectrum of care that you're going to need, the insurer or Medicare or Medicaid is going to say, for that particular illness, I'm going to give you X amount of dollars. You guys figure it out between you how you're going to allocate that, and then the proof of the pudding will be, was the patient treated properly, and was the outcome what was expected? Is that close?
That is close. You're in the right neighborhood.
Well, get me to the correct door.
Let me shift to a different block. You've just very accurately described what we refer to as clinical bundles, and that is a bundled reimbursement for a very specific clinical episode or group of clinical episodes. But there's also bundled arrangements for the total cost of care. So what you're going to see over the next 10 years are the healthcare providers down the street, the integrated delivery systems, the local community hospitals, the tertiary care, urban facilities, academic medical centers, etc. They're all going to kind of split off into four broad categories. Category one being those providers that are volume-oriented, that are still hanging on to at least 50% of their payments coming from fee-for-service. Then you have a second group that we refer to as destination acute care providers, and those are the players that are going to be participating in the bundles that you just referred to, those clinically specific bundles, primarily. That'll be their primary source of revenue. The third group will be the population health managers, and those are going to migrate towards more total cost of care arrangements, and those typically are the providers that have the adequate primary care and ambulatory and post-acute assets to be able to manage the entire continuum of care. And then you'll have the fourth category, which will be somewhat schizophrenic, and that is those providers that are quote-unquote living in two worlds. They're playing in the fee-for-service side, and they're also participating in the bundled arrangements. And that's going to be probably the most difficult organizationally to manage. But they'll kind of break out into those four broad categories.
All right. And so the third one that you described, where it's not only acute, but it's post-acute, meaning the transition from the hospital per se to, let's say, a nursing home for rehab or home for home care with a home care provider or whatever that circumstance may be. And we hear a lot about the hospital bounce back within the 30 days. So are they looking to cover their risk and making sure that the patient doesn't go back? And are they responsible for the patient after that 30-day bounce back?
Yeah, the population health managers that will receive over 50% of their total revenue from total cost of care arrangements are ultimately responsible for everything, for the entire continuum. Ironically, the other players, the more volume-oriented providers, and as well as the living in two world category, are faced with a number of readmission penalties, either through CMS, the Centers for Medicare and Medicaid Services, or through commercial contracts. They're penalized for a variety of clinical conditions if they experience, on a risk-adjusted basis, unnecessary readmissions within certain predefined periods of time. So the risk is not only borne by the population health management group, but also the other players as well. So this readmission, unnecessary readmission, is a serious issue, and it really speaks to a lot of what you talk about on your show, David, that the one of the questions that I ask all of the accountable care organizations that I interact with, there's a fundamental question that I ask of all of them, whether they're moving towards managing populations or not, and that is, if you are going to be managing a continuum of care, whether it's for a specific clinical episode or for the entire, cost of care, how are you going to clinically manage a population in a non-clinical setting? And I get a variety of very interesting answers. Many times the providers default to home health models or other post-acute models, but at the end of the day, the ones that are most effective in mitigating this risk are those that understand how to connect effectively with the unpaid family caregiver that's ultimately responsible or managing the course of treatment for their loved one, whether it's a spouse or a parent or in some cases a child. And we find that the providers that understand not only the clinical issues around the patient's needs, but also the non-clinical, practical problem-solving issues around that unpaid family caregiver, those are the ones that truly understand how to mitigate this risk, because nothing will there's no asset that can be utilized to reduce unnecessary readmissions or increase medication compliance rates than understanding the practical problems that are facing that unpaid family caregiver.
Well, you have been listening to the show.
Ron, they're really the boots on the ground. I mean, they're there every day seeing what's going on. It's good to hear that their value and importance is being recognized and being plugged into the new healthcare system. It's taken a long time.
Well, I would say that journey's only just begun.
Okay.
I cannot sit here and represent that there's a systemic recognition of the need to, practically, in a very pragmatic way, connect with that unpaid family caregiver. But there is a growing awareness of, now that there are higher levels of acuity being downstreamed into lower level care settings, and now that there's this de-emphasis on inpatient care, and now that the financial metrics are aligning with this new awareness of the fact that we cannot afford that a system that's principally dependent upon an inpatient scenario is not sustainable. So this awareness is really only just beginning. To be perfectly candid with you, when you think about moving from a system that is paid based on generating volume to being paid for rendering the appropriate level of care, and I heavily emphasize appropriate, it fundamentally changes many dynamics, and one is these transitional care coordinators, the care coordinators that are ultimately responsible for reaching out to the patient beyond the inpatient episode. They're really beginning to realize the effectiveness of communicating and working through that unpaid family caregiver. And what's right behind that is the realization that most of their needs are not clinical. Ever since 1999, with the Institute of Medicine's "To Err is Human" report, we have re-engineered our system to be very patient-centered, and that was necessary. That's a good thing. But I think we forgot the unpaid family caregiver in the process, and there's a reawakening of the importance of working through that particular resource.
So I guess, Ron, what I could say, because I've known you a long time, you've been taking care of the patient, and I've been out in front of the Indians, huh?
Absolutely. I have to give you a lot of credit, David. You have been sounding the alarm long before the flames were visible, and I think now the flames are visible. And we've got roughly 43 million Americans in this country that are facing this responsibility of being an unpaid family caregiver. And ironically enough, when you think about it on a practical level, if there is an RN in the family, they typically get tagged with that responsibility. So the end result is we have a disproportionate share of unpaid family caregivers within the healthcare sector. And it's really creating presenteeism issues where they're there but they're not there. And that could translate into some patient safety issues. So there's a variety of different ways in which this problem is manifesting itself.
So, in other words, even when we look back at the clinical, because you know this has been a hue and cry of mine for a while, that caregiving in the workplace, even when it's in the clinical workplace, not only reduces productivity, but has an additional element of potentially patient safety. If that nurse or whomsoever comes in, she's tired, it was a tough night with Dad, he wandered all night, if it was a dementia situation or whatever. And you were very right in saying in the family, if there's a nurse, the nurse gets tagged. But, a couple of years back, there was a big survey done that you and I shared at that time from the Journal of Nursing that was trying to figure out who was the most effective person to work with the bundle on the way to coming home for care. And they clearly identified that nurses and social workers just weren't trained for that task. And I know, because a number of my private clients are doctors who are just as frustrated when they become caregivers. When you have an emotional dog in that fight, whether you're a nurse, a doctor, I don't care who it is, all of your practical training gets consumed with the emotion, and your objectivity to figure it out, even if you're the smartest doctor in the world, gets muddled in the responsibility.
Well, it's interesting you say that, because it's just a reality that we default to the clinical based on this erroneous presumption that somehow makes you genetically predisposed to dealing with all of these practical problem-solving issues that come up around the course of treatment of your loved one, and they're two completely separate competencies, and neither of them are intuitive, and both require
an educational component.
Yeah, absolutely. And I would argue that the healthcare providers are getting it from both ends. So they're seeing the ramifications of this erroneous presumption that somebody that has a clinical background in the family should be that informal family caregiver. So they're realizing presenteeism and lack of productivity, and in some cases some patient safety issues. on inside, and on the outside, they're having to deal with one of the primary causes of admissions into the ER in both Dade and Broward County is respite for the caregiver. So they're really experiencing it on both sides.
Sure.
So what you're saying is that people are still using the ER because if you send a 78 or an 82-year-old patient at 8 o'clock at night because you're burned out, you've got a pretty good chance of them being held overnight at least, so that you might get a night's sleep. Would that be kind of what you were trying to get across there?
That's correct, and the providers are just starting to realize that dynamic, and they're making some fundamental changes within the ER and within the intake mechanisms to try and deal with that dynamic. But they're beginning to realize that this problem cuts both ways. It cuts into inefficiencies in terms of how we intake patients, as well as dealing with the fact that we have this disproportionate share of informal or unpaid family caregivers that are clinical caregivers because of this erroneous presumption that we were alluded to earlier. So they're really realizing the negative impacts of us systemically as a society not addressing this problem in a cogent and educated way. The providers are the ones that are really getting it on, from both angles.
Well, Paul has a question.
Yeah, I do. David, Ron, can you stay for a moment or two? We need
Sure.
to take a quick break.
Sure, absolutely.
I have a question for you when you come back.
All right, we're going to take a station break, Ron. Just hold on.
Are you a family caregiver? Are you taking care of a spouse or loved one who can no longer take care of himself or herself? Are you dealing with Alzheimer's disease and don't know what to do? Do you feel burned out, frustrated, and just don't know where to turn? You've tried doctors, lawyers, and mental health professionals and have come to realize that they don't have practical answers to these questions. What you need are experts, non-clinical family caregivers with 25 years of active experience helping thousands of family caregivers like yourself. People who can help you provide a better quality of life for yourself and your loved one. Who you need are David Levy or Paul Vadiato. Reach David at david@caregiverreality.com or reach Paul at caregiverreality.com and let them help you pick the right path towards improving the quality of life for you, the caregiver, and your loved one.
I am Paul Vadiato, president of CareGiver Reality and a full-time spousal caregiver. When I arrive at the office to begin my workday, my caregiving role doesn't get left outside the door. My day is often interrupted dealing with issues at home. That is time not focused on my job. I am but one of the 50 million unpaid family caregivers. Caregiving in the workplace is a costly productivity issue that is only going to increase as our workforce gets older. Caregiver-friendly firms retain hard-to-replace team members, tend to attract better talent, and get out in front of the productivity loss that exists everywhere. Now, new questions are being raised as to possible exposure to discrimination lawsuits as employees question whether their role as a caregiver is damaging them as promotions are denied or reprimands increase that might result in a termination. Caregiving in the workplace, left unaddressed, is costing your firm money, reputation, and possible litigation. CareGiver Reality brings education and training solutions to the workplace. Let our experienced team help evaluate your unique situation. Contact me at paul@caregiverreality.com. That's paul@caregiverreality.com. Do it today.
CFC support helps fund research. You can too. Each year, thousands of men and women serving their country in the U.S. military as well as other employees of the federal government and the U.S. Postal Service, provide support for medical research to find treatments and cures for diseases. This is done through the Combined Federal Campaign, an annual workplace giving campaign that allows eligible individuals to support charities, such as those that conduct medical research, through a payroll deduction. Money donated this way to the medical research charities and its member organizations helps fund research to fight diseases from Alzheimer's to cancer, multiple sclerosis, blindness, breathing disorders, and much more. The diseases included afflict people of all ages, from the very young to the very old. You don't need to be a member of the military or a federal government employee to support research to help you or those you love that are suffering from an illness or disease. Donations to our not-for-profit tax-exempt organizations are tax-deductible and provide a vital source of funding in the fight to defeat some of life's most dreaded diseases. Please visit the website of the Medical Research Charities, which can be found at medicalresearchcharities.org. That's all one word, medicalresearchcharities.org. On that website, you can learn more about our member charities and make a donation in support of the research they're conducting for a specific disease or family of diseases. You can make a donation to Medical Research Charities itself and support the work of all our member charities. Please visit our website today, medicalresearchcharities.org. Become a part of Joining Forces to Find a Cure. This is Caregiver Reality with gerontologist David Levy and caregiver expert Paul Vadiato, who ask you to call in and speak with him on the air toll-free at 888-565-1470. That's 888-565-1470 to share a story or important information. Now, back to today's Caregiver Reality Show.
We're back, and Ron, I appreciate you staying through that commercial. Paul has another question to ask you, and then we'll let you get on your way, because I know you're trying to kick back and get an early start on the July 4th weekend up there in the mountains.
Yes, the soccer game on in the background. Ron, you spoke earlier about population management, and what popped into my mind was this whole question of wellness. And I know for the longest time we've been trying to get people to lose weight and to exercise and to take better care of themselves, and we haven't been too successful with that. And if you're now looking at a system that is going to be focused on better outcomes, how does this whole question of wellness and responsibility come together?
Yeah, that's a great question. When you look at the demographics from the 2010 census, that indicated that we had roughly 50.3 million uninsured Americans in this country. Many of them have migrated either through Medicaid expansion, through the public exchanges, into certain coverage vehicles, or they've migrated through private exchanges into various what we've referred to as precious metal plans. There's a lot of utilization in the bronze and silver category, which can come with it anywhere from $10,000 to $15,000 of total out-of-pocket expense. So while we have migrated many from the uninsured population into the insured ranks, we still have a fairly significant amount of risk, financial risk, that the providers are facing through these higher deductible, higher copay plans, but also a significant amount of financial risk borne by the consumer. And so that has begun to change some behavior as it relates to the
wellness behavior
that lead to chronic conditions. That's correct. So there is some self-regulation going on right now that we've not seen before as it relates to diabetes management, smoking cessation, etc., because now there's more of a significant financial stake that the consumer has in the equation.
So, in Ron, in your world, what we've done is we've shifted some risk to the consumer that historically had been with the provider. As we bring them into the system, whether it's accountable care or whatever is bringing that number of some 50 or 60 million that were uninsured, in getting insurance, we're placing a responsibility on them so that they don't have to get involved with those extensive copays if they just do a little more to stay healthier. Would that be correct?
That's correct, and we have this body of law called EMTALA, which requires hospitals to receive patients irrespective of method of payment in the ER. So we've always, that 50.3 million Americans, they've always had very inefficient access to care, but they've had access to care. Now we're able to deploy more primary care resources to that group and intervene earlier in the equation, so we're not dealing with abject chronic conditions that we didn't have the opportunity to intervene into earlier in the equation. But to your point, you're spot on in that we've shifted an enormous amount of risk from the payers to the consumers and the providers. So that's actually starting to translate into earlier intervention into the 15 major chronic condition categories.
Well, Ron, you, as always, are a wealth of information.
Good Lord, yes.
And as this goes along, I'm hoping in maybe another couple of months you'll come back and give us a little update on how some of this is working, and share some of your knowledge. When you said the precious metals, you were referring to silver, bronze, gold, and platinum programs, I presume.
That's correct.
In your world, they become precious metal programs. But I've always enjoyed that about you, because you have a very interesting speak that comes from the industry, but you break it down very nicely for those of us that don't do industry speak. So I want to thank you again. Have a great July 4th, you and your family, and thank you again so much for being with us.
We appreciate your time, Ron. Thank you.
Thank you. It's been an absolute pleasure, and please keep up the good work.
Okay, we will. And that was Ron Calhoun, and even though sometimes it sounds a little higher in the conversation, I think most of us got the point that things are a-changing, just like everything else, and more responsibility is shifting back and forth because the employer has said, I've had enough, and the direct payer has said, I've hit a wall. So either we're going to get the provider and the consumer to be more responsive by either adjusting what premiums are, adjusting co-pays, or saying to these doctors, you just can't keep seeing a patient on fee-for-service, because that's not the way we're going to be paying going forward.
Well, the bottom line is a dollar can only be cut up so many ways, and there are only so many dollars for health care. And we've been spoiled for so long in so many ways.
Well, because we didn't have the aging world that we are in today, and seeing so much more chronic illness that the Pepsi generation didn't go through, and because our grandparents and our great-grandparents particularly didn't make it much past 65 or 70 before the medical system really got better with antibiotics, better, public health and things like that, and the medicalization of aging. We've kind of jumped over Darwin, and it's not survival of the fittest, it's the survival of those who have been best taken care of by the medical system.
Plus, we've never had such a population group like the baby boomers come into that critical age point of needing more help along the way than we've seen before.
Either for themselves or family members. Right. And I'm sorry, I didn't mean to talk on top of you, Paul.
No, that's okay. But, a lot of the baby boomers are not only dealing with those issues like I am with a spouse, but they're also dealing with mom and dad who lived a lot longer than anyone thought. It definitely is going to have to change, and I think it's going to be very interesting in the years to come how it morphs into a more workable system.
Right, and you've missed one person in that group. You as an individual.
Yes.
All right. You went off.
I'm not allowed to get sick.
Right. Well, I remember, it was 5 or 6 weeks ago, you made it around to all those fee-for-service providers
yes,
to make sure your various bodily functions and organs were in good shape. And I think that that was very wise because, the education and the knowledge about what's going on
I actually caught a problem before it became a serious problem. So you do have to take care of yourself.
Absolutely, there's no question about it. Anyway, we've got about 15 minutes, and one of the things that we wanted to talk about, and I do want to do my shout out for medical research charities.
Please.
We didn't have a chance to do an individual charity tonight because we got caught up in a little more time with Ron, but we love them. They're doing a great job, and we just think the world of the organization. But one of the issues that we're going to be addressing, and it has been one of Paul's pet projects as we've moved forward in this, is the world of addiction. Now, you may say, what has that got to do with caregiving? But I think that Paul and I, as we have explored this, realize that addiction is a disease. And if every disease has a caregiver, then addictions, whether it's alcohol, drugs, whatever it may be, has somebody who's trying to help manage that individual, who has the addiction. And it's more than just interventions, because they have to live with this individual day in and day out. And I think if we recognize that people with addictions can have them for a long time, for a short time, and like any other disease, it can recur. And the family really has to have an understanding, and that primary caregiver is no different than a primary caregiver for any other kind of an illness. And so, Paul, why don't you pick it up from there?
Yes. When we use the word addiction, it really is a generic word because there are many different forms of addiction, and it could be alcohol, drugs, food, gambling, sex, work addiction. They're just a few of the examples. But in each of these addictions, there is going to be a caregiver, and I know David has a favorite word that he uses, that caregiving is agnostic, meaning that it really doesn't pick and choose or care who you are, where you live, how much money you have, how much education you do or you don't have. When you find yourself in that role, it's extraordinarily difficult. And we at Caregiver Reality recognizes that this is a very sensitive subject to be speaking about. And in the weeks to come, what we plan to do is to bring in some experts to look at this from the perspective of what are some of these illnesses, what is available for those that are suffering, seeking help from these diseases, what is available for the caregiver, and what are they facing. So we'll hear from caregivers, we'll hear from clinicians, we'll hear from some people who have are in the process of recovery, and we'll try to understand the challenges that lie ahead. And we're going to hear a first person hopefully next week that's going to tell an incredible story about this. Understanding the components of this whole question of addiction, it's just a monumental task, and as we've done in the past, we're going to break it down into very understandable parts, and we certainly invite your participation into this discussion. We want to hear from you as to what you're going through and how you're coping, how you're problem solving, some of the challenges that you've had to come as caregivers as you work with your loved one who has an addiction of one sort or the other.
And I think this simply represents, in the caregiver reality, to use Ron's words, the spectrum.
Yes.
That many times we get caught up in caregiving and caregiving for elders, which is obviously in an aging world very important. And it kind of gets back a lot of times to focusing on the caregiver who's dealing with some form of dementia. But we can't forget that parents dealing with a child with autism are just as much caregiving as they are parenting. And sometimes that's a tough line for them to realize, and having done work not so much with autism but with children with other problems and dealing with their parents as caregivers, it takes a while for them to realize. And these are people that, just like children that are born with birth defects and other kinds of special needs, are people that may have to be caregivers for their entire life. And so they too need to be recognized and treated a little bit different than someone who all of a sudden has the role for an aging person that may last intensively for a couple of years. But when we look at people and children, as I just described, or those that have had Down syndrome and some of the other birth-related diseases, that their parents are caregivers for 50, 60 years. And the stresses that they go through and the worries that they have, like who's going to take care of my child that I have had in my home who's now 55 but is not socially appropriate to live on his own or her own, and I'm now in my 80s, what's going to happen? These are subjects that we will be bringing up, not to be sensational, but to recognize just how widespread caregiving is, how pervasive it is, and how many lives are really touched by it. Not just here in America, but obviously worldwide. And so when we say that caregiving doesn't care who you are, what the disease may be, or the predicament may be, we're not kidding. And over the months and years, hopefully, that we will be here and talking to you, we will be at the forefront of bringing you the information as well as going back over the basics, because regardless of who you're dealing with, as your loved one, as a patient, as a child, whatever it may be, the basics of caregiving don't change. And so as we add listeners, as we add viewers, as we grow, remember, as an audience, we do have to go back many times to some of the basics. And I've learned that from my support groups. As we add new people, we can't assume that they're up to the same speed as people that have been in a group for a year or two or three. And while everybody's helpful, you do have to give them the ABCs. And while we try and get into the XYZs as well, the ABCs are very important. Paul?
Very good point, David. In the months to come, we are going to look at, across the spectrum of ages, some of the challenges that you, our listeners, are facing with children, adolescents, young people, old people. It matters not. We're going to take a look at these and try to better understand the why and the how of what's going on, and more specifically, how you as a caregiver can do a better job in trying to deal with the challenges presented to you. And as David has told you, it's not intuitive. You don't go to school to learn it, but hopefully what you'll gain from us here are some insights of what we've learned through the years. Caregiving is caregiving.
Right, it is. And not to be self-serving, but my Caregiver Practical Problem-Solving Manual really addresses how you begin, irrespective of what illness it may be, a caregiving plan so that things don't surprise you. And it can be had very, very reasonably on Kindle. Just go to Kindle and put in David Levy Caregiving, and the book Family Caregiver Practical Problem Solving Manual will pop up, and I think it's $7 or $8, and it could be the best $7 or $8 that you ever spent, because this is not how I took care of mom, or respectfully some celebrity telling you what they did when they may have had the dollars and the ability to do things maybe a little bit differently. Not that they didn't suffer just as much, but you as a caregiver need to be able to understand exactly what Ron was talking about and what we talk about every week, the practical problem-solving issues, and the fact that there's no perfection in caregiving, and sometimes just getting through the day is a very, very successful day. So go take a look, David Levy, Caregiving, on Kindle.
Also, David, I invite our listeners to follow us and like us on Facebook. There you're going to find many interesting postings that are updated on a daily basis on what's going on in the news, what are some of the new treatments that are going out there, what are some of the solutions that people are coming up to across a variety of subjects. Our website, another place to go, caregiverreality.com, just loaded with helpful information, and it's there for you to use. Please use that as a resource. You're not going to find that information anywhere else.
Right, and remember, it also has most of the back shows as well as support groups.
Yes.
That I've been, privileged to be able to film, and with the permission of the support group. And you'll hear conversations and dialogue that I guarantee you have heard nowhere else. And the shows, if you've enjoyed them, you may be a recent listener or viewer, and you haven't had the opportunity to go back, and we probably have a good 20 of the back shows that are available to you for nothing at caregiverreality.com. Paul, I know you wanted, because in talking about addiction, we only have a few minutes left, there was a very interesting article that came out, if you can summarize it, from the American Psychological Association, who are a very clinical, oriented organization, as one would expect. But I think that in the world of addiction, they had a couple of very interesting things to say. Why don't you...
Their paper came out, and they spoke about family caregivers who deal with adults with addiction issues. And while they're spoken of often, they've never really been studied. And the clinical community, in many cases, have seen them more of the problem than of the solution. And they're now just beginning to recognize the invaluable role that family caregiving plays in the overall wellness of that person who is seeking recovery. And in fact, the better that they're able to cope, problem solve, manage their stresses, it has a very positive impact on their loved one who has the addiction issue.
And, as we've been talking with folks that are addiction specialists, and getting more information, because one of the most important things that we can do is get our homework straight, and that we don't bring you the wrong information, that we bring you what the industry recognizes. And this article, or rather this recognition by the American Psychological Association of the invaluable care that the caregiver brings, and not just at the time of, let's say, an intervention, but before, as they're trying, just like somebody who's trying to decide whether they should put a loved one into a dementia facility or a nursing home, and the guilt and everything, those same kinds of issues raise themselves as you decide whether or not to put an adult child or your spouse or another loved one in the family into treatment. It brings a lot of the same issues to the forefront. And even when they have gone through that period of seeking help and gaining recovery, we all know that the shoe can fall again. And so preparing the caregiver and supporting the caregiver pre, during, and post is a responsibility that we hope that we can lend more light to as the industry itself starts to recognize the importance.
And one of the issues that we're also going to look at is the reality that in some cases the caregivers themselves in any one of the diseases become so stressed, become so overwrought with the caregiving, they themselves turn to alcohol, painkillers, and such. How do we deal with that? That's something we're going to look at also.
Right, and so South Florida, America, and the world, I want to thank you for listening tonight. Next week we've got another big show. I hope that the USA wins in soccer today.
Yes.
And Paul?
Good night, everyone. Caregivers, take care of yourself. Have a great week.
Thanks for joining us for this week's Caregiver Reality Show. Each week, David Levy, a gerontologist, and Paul Vadiato, a caregiver expert with a combined over 25 years of experience providing practical and realistic help to caregivers struggling to keep up with the needs of a loved one who are unable to care for himself or herself. To reach David Levy, email him at david@caregiverreality.com. Or to reach Paul Vadiato, email paul@caregiverreality.com. And find out more online. Just go to caregiverreality.com. See you next week for another exciting show of Caregiver Reality. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers, and not necessarily those of the station, its staff, management, or sponsors.